Obesity is a risk factor for non-communicable diseases like type 2 diabetes, cardiovascular disease and several types of cancers such as breast, large intestine, pancreas and kidney cancers. In the 2019 National Health and Morbidity Survey, 50.1% of our adult population were reported to be overweight or obese. Treatment of the overweight and obese patient is a two-step process: assessment and management. Assessment requires determination of the degree of obesity using body mass index and waist circumference and absolute risk status. In assessment, bone mass index is recommended as a practical approach for the clinical setting. It provides a more accurate measure of total body fat than relying on weight alone. The waist circumference should also be used to assess abdominal fat content. It is the most practical measurement for assessing a patient's abdominal fat content before and during weight loss treatment. Fat located in the abdominal region is associated with greater health risks than that in peripheral regions. And studies suggest that the visceral fat component of abdominal fat is the most strongly correlated with risk factors. The patient's risk status should be assessed based on BMI, the presence of abdominal obesity based on waist circumference, and the presence of concomitant cardiovascular risk factors or comorbidities. The identification of risk factors is required as a guide to the intensity of intervention and weight management plan. It is important to ask the patient whether or not they want to lose weight. Patient involvement and investment in weight management efforts is crucial to success. The goals of weight management could vary among individuals in a weight management therapy include reduce weight, maintain weight or reduce health risks. For those targeting to lose weight, guideline recommends as an initial goal the loss of 10% from baseline weight in a 6-month period, to be lost at a rate of 0.5 to 1 kg per week. Rapid weight reduction is not recommended as it may lead to increased risk of gallstones, electrolyte abnormalities and weight regain. Most patients will require maintenance or prevention of weight gain if they are to lose more weight. During the acute weight loss period and at 6-month and 1-year follow-up, the patients should be assessed of progress to readjust goal or target. For patients who continue on weight maintenance efforts, the reasonable target are to have weight regain of less than 3 kg in 2 years or sustained reduction in waist circumference of at least 4 cm. There are various approaches of weight loss therapy. The methods are dietary therapy, increased physical activity, behavior therapy and pharmacotherapy approach. In the majority of weight management plan, adjustment of the diet to reduce caloric intake will be required. The key recommendation is the reduced caloric intake to achieve a slow but progressive weight loss. A diet that is individually planned to help create a deficit of 500 to 1000 kilocalorie per day should be an integral part of any program. Physical activity contributes to weight loss, both alone and when it is combined with dietary therapy. For weight loss, moderate levels of physical activity for 30 to 45 minutes, 3 to 5 days per week should be encouraged. The success of weight loss involves individuals' decisions and interventions. This can be complex and often involve engagement in behaviors that affect their health and well-being. Behavioral strategies to reinforce changes in diet and physical activity to produce a weight loss in obese adults. Some example of behavior therapy strategies useful for weight loss and weight maintenance programs include self-monitoring of both eating habits and physical activity, stress management, meal replacement plans. Appropriate weight loss drugs may enhance effect of diet, physical activity, and behavior therapy in weight loss. The benefit of pharmacotherapy must be carefully weighed against risks of side effects. The two common medication found are orlistat and phentermine. Since obesity is a chronic disorder, the short-term use of drugs is not helpful. The health professional should consider the risk/benefit ratio of using medication. Pharmacists can actively intervene and play a key role in obesity management. In the provision of weight management services, the pharmacist could assess patient's status, assess readiness to change and make reasonable plan. Monitoring is also essential.